Lesson 1: Understanding Healthcare Denial Management. Before we begin, if this information helps you better understand healthcare denial management, please take a moment to like this video and subscribe to the channel. Your support helps us continue creating practical information that healthcare professionals can actually use. Today, I want to begin with the most important question in denial management. What exactly is a denial? That sounds like a simple question, but the answer is more important than many people realize. A denial is not simply a claim that did not get paid. A denial is information. It is a signal. It is evidence that something happened somewhere between the delivery of a healthcare service and the payment for that service. Sometimes the problem occurred before the patient ever received care. Sometimes it happened during registration. Sometimes it involved insurance eligibility. Sometimes authorization was missing. Sometimes the documentation did not support the service that was billed. Sometimes the coding did not accurately represent the care that was provided. Sometimes the payer interpreted its own policy differently than the provider expected. And sometimes the organization did everything correctly and the payer still denied the claim. That is why denial management is much more complicated than simply taking a denied claim and trying to get it paid. True denial management begins with understanding why the denial happened. And that distinction is going to be one of the central themes of this entire series. For many healthcare organizations, denial management becomes a recovery operation. A claim is denied. Someone receives the denial. Someone researches it. Someone corrects the problem. Someone sends an appeal. And eventually, the organization either gets paid or writes the balance off. That process is important. Organizations absolutely need knowledgeable people who know how to work denied claims. But if we stop there, we are missing an enormous opportunity, because every denial contains information about the process that produced it. And when we begin collecting that information across hundreds, thousands, or even millions of claims, patterns begin to appear. That is where denial management becomes something much more powerful. It becomes denial prevention. Let me give you a very simple example. Imagine that a hospital receives a denial because a required authorization was not obtained. The immediate response is to work that denial. The staff may contact the payer. They may research the authorization history. They may appeal. They may request a retrospective authorization. They may attempt to demonstrate medical necessity. Those activities are designed to resolve that individual account. But there is another question that needs to be asked. Why was the authorization missing? Was the patient scheduled before the authorization process was completed? Did someone misunderstand the payer requirements? Was the authorization obtained but entered incorrectly? Did the payer change its policy? Was the service performed differently than what had originally been authorized? Did a communication breakdown occur between the physician office and the hospital? Those are very different problems. Yet all of them may eventually appear on a report under the category of authorization denial. That is exactly why the original denial reason is not always the same thing as the root cause, and understanding that difference is critical. A denial reason tells you what the payer said. A root cause tells you what actually created the problem. If you work in healthcare revenue cycle or denial management, that distinction alone can completely change the way you look at your data. And if this is the kind of practical discussion that is useful to you, please like this video and subscribe. We are going to build on these concepts throughout this entire series. Now let us look at another example. Suppose the payer denies a claim because the medical record does not support the level of service that was billed. Again, the denial needs to be worked. The organization may review the documentation. A coder may review the claim. A physician advisor may become involved. Clinical staff may prepare an appeal. Supporting documentation may be submitted. But once again, we need to ask why. Did the physician fail to document an important condition? Was the documentation present but difficult to locate? Was the code incorrect? Was the payer using a different clinical interpretation? Was there a documentation education issue? Was there a coding education issue? Or was the claim correct and the payer simply made an inappropriate denial? Each answer leads to a different corrective action. That is the real power of root cause analysis. If the issue is documentation, you educate the people responsible for documentation. If the issue is coding, you examine coding.